Deep breath out. Ready to start an awesome conference. All right, here we go.
Thank you.
Oh, we've got some. Well, great to see so many people here. Thank you for showing up. And I apologize for starting late, but we didn't want to leave people standing in line, so glad everybody made it in. And just a word about the confidentiality agreement. It's not about anything confidential about the training or what we're going to tell you. One of the nice things about working for MAPS is nothing is proprietary. You know, we want to make everything we do except for participant information available to everybody. So it's not about that, but it's very much about, we are going to show you some video clips that one of the veterans in our study has allowed us to show, and it's about those that we want you to keep confidentiality and not share anything about what you see in the specifics of the video clips. And the same goes for recording. This is going to be recorded anyway, and we're fine if you want to record anything we say, but it's not okay to record the videos, please. Because when the recording goes up, those will be taken out. So, is my thing a little loud? It sounds like it. Hey, Brian, could you turn my mic down a little bit, please? Thanks. How's that? You hear me okay? Can you hear in the back okay? Great. And please, at any time, if you're having trouble hearing us or hearing the video or seeing anything, please wave your hand, and we have a great technician over here that can help with that. Well, we really appreciate that this many people wanted to come this year, and it also presents a bit of a challenge in that we also want to make this as interactive as possible, which is a little more challenging with this many people, but I think let's interact and connect as much as we can. And as we go along, I think with this many people, probably the best thing to do is we're going to pause periodically for more time for discussion and questions, and to save most of that for those periods. But then if there's something that's really not clear, please raise your hand and we'll stop and clear it up. But if it's something that can kind of wait till the end of that section, that might be a better way to do it. We can sort of feel it out as we go along. And there will be 2 wireless mics that someone will be bringing around. So if you want to say something, please raise your hand and then wait for the mic to arrive at where you are. And that way it'll not only make it onto the tape, the recording, but everybody else will be able to hear you. So, you want to say anything at this point, Annie?
It's good to be here and see so many people and see some people that we know and some new people. And so I'm really excited about the day.
So since we don't have time for personal introductions for everybody, because we'd love to, if we could know more about everybody, but maybe we could start by just kind of getting a feel for who's here. Maybe could everyone who's a practicing therapist raise your hand? Thanks.
How about students? Mm-hmm.
Thanks. Physicians?
Nurses?
Cool. Anything else important I'm missing?
Lawyers.
Lawyers, okay. Thank you.
What? Carpenters?
Witches? People who have been cured of PTSD. Thanks for coming. So maybe I'll just give you a overview of the schedule today to start with. Don't want to be too redundant about things we've talked about before, but we're not sure where everybody is, so we're going to just talk very briefly about some of the history of MDMA, the phases of research, a little bit about PTSD, and then, why we thought that and think it's a good idea to look at MDMA for PTSD, and then kind of give you just a quick review of some of the results of our clinical trials. So basically to show you that, yes, this does seem to work before we then go into spending most of the day talking about like what our approach to therapy is. So we'll have a break in the morning, and then we'll start to talk about the therapeutic method after the break. Thank you. And then we'll have lunch from 12:30 to 2, and then we'll talk more about the specific elements of the different parts of the MDMA-assisted therapy, the preparatory sessions, the MDMA sessions themselves, the integration sessions, and then we'll have some short video clips to give examples along the way. So, and really part of our goal is to emphasize how important we think the preparation and integration sessions are. And then we'll talk a little bit about therapist self-care, about our training program that we have going on, and have as much discussion as we can. And we don't have a lot of references, but this is our investigator's brochure is basically a review of all the English language literature on MDMA, and Ilse Jerome, who works for MAPS, updates this twice a year, so it's a really good source to find references. Actually, first I want to give a little perspective about how we feel about what we're presenting. We're well aware, we have quite a lot of experience with this now over the 17 years we've been working on this research, but we're also aware of how much we learn from people who have gone before, and how many that there are people who have a lot more experience than we do. So what we're not presenting this as certainly the only way, or perhaps even the best way to work with MDMA. We're presenting it as a way that we've found to be effective. We like it. And also, the reason we have a manual is for research purposes, largely, because in order to make the research valid, we knew we had to be doing, basically the same thing in different studies, or whether people got placebo or got MDMA, and in different sites now around the world. We've had research at various sites. So it's an attempt to make sure we're, doing basically the same approach. And when we, back in 2000, when we started working on the first protocol, we kind of knew in the back of our minds that we would, at that time it was only one site with me and Annie, so reproducibility wasn't so much a problem, although we did need to have some way to show that we were working with the people in the same way, whether they got placebo or MDMA. But, our first thought about, doing a manual was, we don't really like manuals, and this is too intuitive and variable and oriented toward the individual process, so how could you have a manual for that? So we kept not doing the manual for a few years, but every time we, periodically we'd kind of get over that and realize we do have to have a manual. So we decided, well, is this still a little Does this seem loud out there? I guess it's just up here. Okay. I'll deal with it then. I just didn't want to be shouting in your ears. So we decided, well, we're going to have a manual if we're going to carry this research forward into multiple trials. And we should be able to describe what we think we're doing in a coherent way that people could understand, and also allow for the flexibility. So the reason I'm going into this in some detail is we're going to kind of use the bare bones of the manual to talk about the different kinds of sessions. So so we wrote a manual that does allow for a lot of flexibility, and we'll talk a lot more about that. So it's not meant to be too rigid, but it is meant to describe what we think are the essential elements of this particular approach, leaving room for flexibility. And so, not really being manual people, when we finished writing it, we wondered, I wonder if a manual person would think this is a real manual, since it allows for quite a lot of flexibility. So we hired a consultant in Chicago, a psychologist who writes manuals, and she reviewed it, and she said, yeah, this is a manual. This seems valid. So we thought, well, that's good news. And then actually, about 3 years ago, we were in conversation with the PTSD section of the National Institute of Mental Health and talking to them about possible grants, and they actually were quite helpful, and we asked them if we could give our manual to their manual, the National Institute of Mental Health manual division of the PTSD division. And so we did that, and they reviewed it, and they said, yeah, this is a valid manual. It's actually a good manual. So that was kind of good to hear, I guess. You know, it made me a little nervous. Maybe we did too good a job of making it a manual, but anyway, that's so. And then in order to see if we're following the manual, then we had to have adherence measures. So basically, we took out the kind of essential features of preparatory sessions, experimental sessions, which is what we call the MDMA or placebo sessions, and integration sessions, which is what we call the follow-up sessions. So we just pretty much wrote down what we thought were the essentials of that, and then we trained a bunch of adherence raters and refined those based on help from the adherence raters once they started using them. So now all our sessions are videotaped at all the research sites, and then adherence raters watch a percentage of the videos and kind of score, yes, are we sticking with what we say we're doing. So we've used the adherence measures, you'll see them all day coming up. We've used kind of the adherence measures, the basic elements of each kind of session, just as a kind of way to structure our discussion. Does that make sense? Any questions about that? So this is MDMA. I think, how many people don't know that much about the history of MDMA? Okay, good. So MDMA, I'm not going to talk much about the chemistry. There are a lot of experts in that at this meeting. If you talk to Dave Nichols and people like that for details, but it was patented by Merck in 1914, and they looked at it as a possible precursor to other drugs and never actually did anything with it. It wasn't until in the 70s when Alexander Sasha Shulgin synthesized some and tried it and gave it to his friend Leo Zeff, a therapist, that it started to come into use as a therapeutic catalyst. And it's often lumped with psychedelics, which in one way that's a correct term because psychedelic means mind manifesting. But it's so different from classic psychedelics like LSD or psilocybin So that actually Dave Nichols suggested the word entactogen, meaning to touch within, which I think is a pretty good word for it. It helps people kind of touch within. And so, you know, we're studying it under FDA investigational new drug application. So, but it's actually not new because it was in use as a catalyst to therapy between the late 70s and 1985 when it finally became illegal. So there were those years where therapists, quite a number of therapists, were using it as a catalyst to therapy, but it wasn't an approved drug, but it was not illegal either. And then that got shut down when the DEA put it into Schedule 1. And you know, there were case reports of the use in that time. George Greer and Rico Talbert published this case series. They're going to be here. They're here at this meeting. But there was no controlled research done at that point. And here's what I've been talking about. Alexander Shulgin started out with it and published a report about human use along with Dave Nichols, a chemist from Purdue. And probably about 4,000 psychiatrists and other therapists were using it in the early 80s. Those are some of the reports. And there was a period in Switzerland for 5 years, or about 5 years in the 88 to 93, when they had permission to use MDMA, LSD, and psilocybin therapeutically, but that ended because they had some problems later. Can people see the slides okay? And I notice of course you're welcome to take notes, but also, you know, we'll share the slides with you later if you want. So it was when it became you know, more widely recreationally used that the DEA started to look into it, and they put it in Schedule 3 in 1985. And there were hearings with a number of, you know, prominent psychiatrists testifying that they thought it had medical use, so that the DEA administrative judge actually recommended that it be put in Schedule 3, so it could be used by physicians but not sold in bars. But the DEA administrator overruled that and put it in Schedule 1 anyway. And so, of course, all the legal therapeutic use stopped. It became very difficult to do research, and the recreational use went through the roof, so it didn't appear to be the most effective public policy. So just so you'll understand, when we're talking about the research, the FDA, basically MAPS is acting like a nonprofit drug company, which is a very unusual thing. I don't think most people thought it was possible for a small organization like this to get to starting phase 3 trials in drug development, but it has happened. So watch out. So there's preclinical studies giving, you know, animal studies are the first thing. And one good thing about MDMA's checkered past is that because of the recreational use, a lot of government spent many millions of dollars on preclinical research with MDMA, so MAPS didn't have to raise all that money. And then the next phase is when a drug is given to healthy volunteers to measure toxicology, pharmacology, physiology. And Charlie Grobe at UCLA did the first of those, and then there had been a total of 3 of those in the US by the time we started our phase 2 trial, which we submitted the application for in 2001 and then actually started in 2004. So after phase 1 trials in healthy volunteers, then you move on to phase 2 trials, which are relatively small clinical trials studying safety and treatment effects in a population of people that have a diagnosis. So we chose PTSD as the diagnosis that we were going to focus on studying. So now, I'll show you later, MAPS has now done 6 phase 3 trials.
Phase 2.
Phase 2, and then we've just gotten the go-ahead to move into phase 3, which are similar to phase 2, but much larger and multi-centers, and the FDA requires usually 2 of those to approve a drug for clinical use. So we're just embarking on phase 3. And then there's this other interesting thing called expanded access, which means that normally you have to wait until end of phase 3 and approval before a drug can start being used clinically. But there's this category of expanded access which we're going to apply for, and we are told we have a good chance of getting, which will mean that once we get the phase 3 trials going in early 2018, most likely, sometime during that year, when the phase 3 trials are going well enough, we'll be able to apply for expanded access, which would mean it's possible to have limited use outside of clinical trials. So therapists who have been trained with our program, not this program, this is kind of a condensed version, but I'll tell you more about the full training program. But therapists that have been through that training program, if expanded access is granted by FDA, will then be able to use MDMA-assisted therapy for PTSD outside of the clinical trials and collect safety data. They won't have to collect outcome data probably, but to add to the safety data. So that's a real possibility for some time in maybe late 2018. We still don't know for sure. So, as I said, there have been lots of preclinical use. Charlie Grove published the first phase 1 trial in '96, and our first phase 2 trial was completed in 2008. We'll talk a little bit more about that. And that's been published along with the long-term follow-up. It was published in 2013. And as I said, now there have been 6 MAPS phase 2 trials, which I'll review the data for briefly. So at the end of those 6 phase 2 trials, this was a picture from our end of phase 2 meeting with FDA in November, at which, we didn't know. They could have easily said you have to do more phase 3 trials or you have to do more safety studies before you can do phase 3, but after a good conversation with them about some of the details, they agreed that we were cleared to move forward to phase 3. So the protocol is in the approval process. They didn't approve the specific protocol that day, but they said you don't need to do anything else before you can move to phase 3. So we've had a couple back and forths about the details of the protocol, but there's no question that it will be approved, and they've actually agreed to the important things that could have been sticking points. So how many people don't know too much about PTSD? Okay, a few. So we're not going to go into great detail, but post-traumatic stress disorder is something that develops after trauma, such as childhood abuse, rape, war, automobile accidents, and things like that. And everyone, or most people, are going to have quite a few symptoms immediately after the trauma, but PTSD is when those things don't naturally resolve over the ensuing month or so. So there are 4 basic categories of symptoms of PTSD: re-experiencing symptoms, flashbacks, intrusive memories, nightmares, things like that. Avoidance, either avoiding the things that remind people of the trauma, or it also kind of inner avoidance, emotional numbing can be a very prominent part of it. So, and often people with PTSD have some of each. You know, they can be easily overwhelmed by emotions that get triggered, and they can also be really cut off from emotions. And there's this category of like negative alterations in cognitions and mood, kind of like thinking and feeling is kind of skewed to the negative, toward the negative. And then there are hyperarousal symptoms, anxiety, panic, difficulty sleeping, increased startle response, hypervigilance, that kind of thing. So it's really a debilitating condition for many, many people. And there's often a lot of dissociation with PTSD, and there's now a subtype that has of people with higher degrees of dissociation. This is a very brief summary of existing treatment for PTSD. You know, pharmaceutical drugs can help with the symptoms. SSRIs are the only approved drugs. Paxil and Zoloft are actually the only two drugs with FDA approval for PTSD. Many other drugs are used, but it's clearly, nobody thinks it's a definitive treatment for PTSD. This is a list of prior medications of one of the firefighters from New York who was at the World Trade Center, who was in our most recent study. I don't know if you can read them all, but you don't really need to. Basically, several members of every class of psychiatric drugs were tried, some of which have serious side effects. You know, there's several antipsychotics on there that, you know, cause weight gain, metabolic syndrome, risk for diabetes, heart attack, stroke, you know, not trivial side effects. And these are all medicines that have to be taken every day for the most part. And obviously they weren't terribly effective, or he wouldn't have volunteered to be in our study. So and this is not atypical. So many people we see coming to the studies have been tried many different medications without much help. So psychotherapy is clearly the definitive treatment for PTSD, not medications. And you know, one of the important points about what we're doing is we're not just doing drug trials, we're studying drug-assisted psychotherapy, which is a nice model because the drugs don't have to be taken very often. So, you know, the good news is that in recent decades, there has been more and more research about specific treatments for trauma-focused therapies, which has led to some advances. The bad news is that still at least 50% of people don't respond adequately to existing treatments, and that's a lot of people, millions of people in the U.S. alone, and of course high rates in veterans, and high rates of suicide in veterans. And in last year, there were 868,000 veterans in the U.S. with PTSD diagnosis. So it's a lot of people and a lot of failed treatment. Okay, yeah, so, you know, the common existing therapies for PTSD, just briefly, cognitive behavioral therapies, prolonged exposure and cognitive processing therapy are probably the two best researched ones. EMDR has a lot of evidence for it, and psychodynamic psychotherapy is also in the American Psychiatric Association list of treatments for PTSD. And then actually there are a lot of other therapies that I think are more interesting. Internal family systems, ACOMI, sensory motor therapies. And you know, those are less mainstream, but still pretty widely used. And then there are other techniques for kind of catalyzing the therapeutic process. Holotropic breath work is one of them. It's been going on. I think it's going on right now upstairs. That's a great process. And then there are things like virtual reality. Some other drugs have been used, and then there's MDMA. So this is a kind of a category of recognizing therapy as the main thing, asking, is there a way that drugs could actually catalyze or help with the therapy? So that's kind of what we're doing. I keep pushing the wrong button, I guess. And so, one thing I think that we really notice about our MDMA sessions is elements of many of these other approaches come up during the MDMA sessions. It's just that in our approach, we don't direct that. It happens spontaneously. We'll talk much more about it. We encourage people to be open to whatever might come. But if you look at what does come, therapists using these other methods would recognize a lot of what happens spontaneously in the MDMA sessions that may happen under a more directive approach with the other methods. So it's not as strange as it sounds. And this is just you can find this for free in the MAPS bulletin. I wrote an article a few years ago about this, what we've noticed about the elements of other therapies coming up in MDMA sessions, if you're interested in more detail. But it's kind of one thing is, what it has in common with cognitive behavioral therapy is often people recognize their own cognitive distortions and kind of the underlying assumptions that lead to those. And, that's very much the part of what happens with cognitive behavioral therapy, but we don't direct that. It just tends to happen. Sorry. Prolonged exposure, that's a lot of prolonged exposure is imaginal exposure, where you ask people to go over the trauma, repeat the trauma script. We never ask people to do that, but almost inevitably, at some point, part of what happens for people is they end up doing imaginal exposure. They revisit and kind of deeply process and go over the trauma. But we let that happen spontaneously according to the person's own process, rather than saying, now it's time to talk about the trauma. We never say, now it's time to talk about the trauma. Internal family systems is one way of working with parts, and we've really noticed that I happen to be trained in that, and Annie's done quite a bit of training. We notice how often people start recognizing their parts and kind of unblending from their parts. How many people are familiar with internal family systems therapy? Oh, cool. So, people, MDMA seems to really often stimulate more awareness of parts and a greater ability to what's called unblending, to not be caught in a part, but to recognize it and talk about it. And we found that a very useful part of what happens for a lot of people. Again, not all of these happen for everybody, but most of these happen for most people. And then Annie's trained in Hakomi. How many people are trained in Hakomi? Yeah. You want to say something about that?
No. Keep going. But the present moment experience, I think that, Hakomi talks about is something that happens for a lot of people with MDMA, that they finally are really in the present moment, not in the past and not thinking about the future, but really feeling what it's like to be in the present.
And then, body-oriented therapies. How many people are somatic experiencing or other somatic kind of therapists?
Yeah.
Great, yeah. So we really pay a lot of attention to what happens in the body, and we'll talk more about that, but that's an important thing, that energy movement release of the body tensions, and sometimes we do some body work with people. And of course, a lot of psychodynamic stuff comes up. There's a lot of MDMA can really heighten transference. And often people address early life experience and family dynamics. You know, they may come in with trauma from their Humvee being blown up, but inevitably they, with a non-directive approach, they inevitably kind of revisit and work with other elements of their biography. And we're going to talk more about Stan Groff, who's doing the breath work upstairs. And it's been one of our main teachers about, you know, the way he talks about this whole thing we're doing is we're working with the healing potential of non-ordinary states of consciousness. The idea is if you go into a non-ordinary state of consciousness with the right mindset and support, that it has great healing potential. And there's, you know, from a Jungian perspective, there's a lot of powerful archetypal imagery that comes up in the sessions and is always a really powerful and interesting part of the healing process. Any comments or questions about any of that? Okay. So I'm not going to talk in detail about MDMA pharmacology, but you know, it does cause, one of the main effects is release of serotonin and activation of some serotonin receptors, also norepinephrine and dopamine release, other neurotransmitters, as well as increasing levels of various hormones, including prolactin and oxytocin. So Ben Sessa, who's going to be speaking here, he's a psychiatrist from UK who's doing MDMA research. He's got a really nice chart about how you could relate specific pharmacological effects to the therapeutic effects of MDMA. So I'll let you go to Ben's talk, and we won't spend too much time on that today, but it's pretty interesting. And this is from another person who's speaking here today, this week, Robin Carhart Harris in England, just showing a little bit about the brain imaging that's been done. And I guess this one doesn't have the circles on it. Anyway, I don't know how well you can see this, but basically, Robin and other researchers have found decreased activity in the amygdala, you know, the fear centers, if you will. So, and it's not on this slide, but other people have shown increased activity in the prefrontal cortex. So, a lot of what we're going to talk about is people being able to have their fear settled down enough so that they can process the trauma in a different way. And that fits nicely with what's being seen on the brain imaging. And also, you see the changes in resting state functional connectivity, which is really complicated. But basically, that they're seeing, not only looking at what areas are more or less active, but like what networks are connecting or activated and connecting to each other. And so Robin's written about, you know, the way that these changes in functional connectivity kind of free the brain from this more constrained, old, stuck way of processing to give it a lot more options. And that also really fits with what we're seeing clinically. And in a therapeutic context, as probably all of you know, MDMA can enhance feelings of empathy and connectedness, increase feelings of acceptance, reduce fear and defensiveness, increase interpersonal trust, and sort of put people in a state of consciousness where there's more insight and creativity, kind of very much going along with what Robin's Carhart Harris is talking about the less constrained functioning. Of course, like any drug, MDMA has risks as well as benefits. There's been a lot of research and discussion over the years about MDMA toxicity, so I'm not going to spend a lot of time on that because thankfully it's not doesn't come up nearly as much as it used to, but it does have toxicities. There's the acute toxicity. Hyperthermia and hyponatremia have been the most common causes of death. People can die from MDMA. It's usually been, it's never happened in a controlled research setting, but it's happened in recreational settings. And one of the common causes is people get overheated, hyperthermia, dehydrated from, prolonged dancing and inadequate fluid intake. And conversely, a few people have died from drinking too much fluid, from brain edema. In an attempt to avoid dehydration, several people have drunk really large quantities of water in a short period of time, and MDMA does interfere with clearance of water, which isn't a serious problem if you're not drinking too much water, but it can be fatal. So it's, like any other drug, it's not to be taken lightly, and it can be toxic. It's pretty rare. The serious toxicity is pretty rare, given that millions of people are taking at least what's supposed to be MDMA every weekend and have been for many years. So, but still, we need to pay attention to the fact that careful use is really important. And then, so as I said, there hasn't been serious toxicity in clinical trials, and now in not only our trials, but in all a lot of phase 1 trials as well. There have been now over 1,600 people exposed to MDMA in clinical trials without any serious, no fatalities. I can't quite say no serious adverse events, but no really serious adverse events. These are the 6 most common reactions we see. And something happened to my boxes on this version. But anyway, don't need to worry about all the details. But we do see anxiety, fatigue, headache, jaw clenching, lack of appetite, nausea. Those are the most common ones during the MDMA sessions and afterwards. And they do happen with inactive placebo, but they are these ones are more common with MDMA. And the MDMA affects blood pressure and pulse quite a lot, which is one reason we screen people carefully and don't enroll people with cardiovascular disease, because it could be dangerous if people couldn't tolerate having their blood pressure go up. And just those are the maximum values with our higher dose, 125. You can see people's blood pressure does go up quite a bit. Their heart rate can go up quite a bit, and their temperature tends to go up a little bit. It goes up, it comes down. We've never had to treat any of this. It hasn't been a problem, but it could be in somebody that had an underlying illness. These are the percentage of people with serious adverse events in the MDMA, the MAPS MDMA studies, and whether or not related to MDMA. So clearly, this person that broke their clavicle 40 days after their MDMA session, probably not related to MDMA. But there was one person who had an increase in extraventricular premature beats, heartbeats, in our study, who we admitted him to the hospital overnight for observation. It turned out to be fine, and he was able to go home the next day. Didn't have had a full workup, but that did require some extra monitoring. And and we've had a couple people have an increase in suicidal thoughts. These have been people who had a lot of suicidal thoughts beforehand, people with PTSD. So it's all, like any drug, it's all about risk-benefit. And what we found so far is the risk-benefit ratio seems to be quite favorable for MDMA. So one way we think about it is that MDMA magnifies whatever is there. So people can have some very affirming experiences. You know, a lot of the talk about MDMA is how much it can bring these positive affirming experiences, but also it can bring difficult, painful experiences. And it's not all about just getting blissed out and everything's okay if you have PTSD, or for any of us for that matter. And several people have said this. So that really emphasizes that. You know, most of the people with PTSD have said, you know, that was difficult, but it was worth it. So it's really, and we're, as we'll talk more about, and we think the difficult experiences are a very important part of the healing, as well as the affirming experiences. So why MDMA for PTSD? I guess because Rick and I decided that when we first met in 2000, but we had some reasons for that. You know, as we said, psychotherapy is the definitive treatment for PTSD, but it often doesn't work. And when it doesn't work, these are some of the possible reasons. You know, either there's so much anxiety, fear comes up that people either aren't willing to revisit their trauma, or if they do it, it can even be re-traumatizing if there's too much fear coming up. Conversely, if there's too much defensiveness, emotional numbing, they might be able to talk about the trauma, but if they're not emotionally engaged, then it doesn't tend to be effective. And also, people with PTSD have a lot of trouble often forming a therapeutic relationship. So lack of trust can be an obstacle to effective treatment. So if PTSD if MDMA can decrease fear and defensiveness, increase trust and empathy, it makes sense that it might be helpful for people that who don't respond to the therapy without it. And there's this idea of a window of tolerance. This comes from other therapies. I mean, we didn't just notice this with MDMA, but people treating PTSD have noticed for a long time that this problem of either being overwhelmed by fear or being emotionally numb. So this is from Pat Ogden about this idea of the window of tolerance. So if the vertical axis is the arousal curve, the level of arousal, if people are hyper-aroused, overwhelmed by emotion, kind of disorganized processing, they can't really process the trauma effectively. If they're hypo-aroused, numbed out, kind of disabled processing, then the therapy doesn't tend to be effective. So there's this idea, there's this window of tolerance or optimal arousal zone in between. And we think that one thing MDMA does is give people several hours in this optimal arousal zone that allows them to process the trauma in a way that they hadn't been able to before. And that fits with that brain imaging I was talking about before. So, that's one way to think about it. How does MDMA help to overcome the obstacles to the main existing therapies for PTSD? But I think that's a fruitful avenue of inquiry. But also, it's a bigger picture than that, and it also makes sense to think about, okay, what is not included? If MDMA can help make the things that are included in existing therapies more effective, great. but also what is missing from the existing therapies that MDMA may offer as well. And I think this is a helpful way to think about that. Bessel van der Kolk, who is a psychiatrist in Boston, who has written a lot about PTSD, and he has a recent book, The Body Keeps the Score. How many people have seen it, are familiar with that book?
It's a really good book.
Oh, cool.
Yeah.
Great. So, Bessel talks about the fact that you need, there are kind of three fundamental avenues for healing trauma. One is top-down processing, which is kind of what we've been talking about, what most mainstream therapies are directed toward, talking about the trauma, reconnecting with others, understanding, accepting, processing the memories by talking about it and in relation to other people. Very important, but not enough in itself often. So then there's the fact that you often can't do that, the top-down processing, unless you can kind of modulate the fear reaction. These are his words, shutting down inappropriate alarm reactions. I might say more like settling down inappropriate alarm reactions and, changing the way the brain organizes information. So both of those things that we saw in those imaging slides, doing something about that fact that the limbic system, the fear center, has hijacked the rest of the brain, and also doing something about the fact that the brain is stuck in these limited patterns of functioning, or the brain/mind. So doing something directly about those is often necessary, because just top-down processing doesn't work if you're constantly hijacked by fear. And then there's bottom-up processing, which is basically including the body. And Bessel talks about the importance of the body having direct experiences that are, kind of different from the being stuck in the trauma. So that kind of deeply and viscerally corrective experiences, as he says, that contradict the helplessness, rage, and collapse that results from trauma. So most trauma therapies do not include all three of these. So I think part of what we're trying to do with MDMA is catalyze the top-down processing that's already prominent in the most common therapies, but we're also trying to include these other kinds of processing. And we don't really have to try. The MDMA tends to bring those things in. So if you look at that and where the state of affairs is, I'm kind of taking off from that. It seems that psychotherapy for trauma needs several different features. One is something to catalyze the processing in the first place, and to help people reconnect with others, which is part of that top-down processing. So to catalyze that process, to do something about the, brain hijacking the whole process with the fear by modulating the fear reactions and giving a wider repertoire, a less constrained repertoire of functional connectivity. And then another part is affirming experiences can be so important. Kind of like Bessel says, that deep and visceral corrective experience and more compassion for yourself and others. And also a broader scope to not, if you're over-focused on people processing the trauma, you might miss some of the most important processing that person needs, which might be about what happened in childhood that made them susceptible to PTSD in the first place. So we thought it sounded like a good job for MDMA-assisted therapy. Actually, the process for us was backwards. We started doing the MDMA-assisted therapy and then came up with this list. But So any comments or questions about that background?
I think there's one here.
Yeah, do we have somebody with a microphone?
Yeah, she's
Cool,
coming
here
down.
it comes.
Yeah, hi. I just had a question about the suicidal thoughts. If you could talk a little bit about that. I was curious if that's what you saw was a permanent increase in suicidal thoughts, or is that like an initial acute reaction and then throughout the course of therapy it decreased or stayed the same? Or
Oh, yeah, thanks. No, it was not a permanent increase in suicidal thoughts. Actually, the one person that we had that went in the hospital because of that, it was a veteran who had had 3 serious suicide attempts before enrolling in the study and had chronic suicidal thinking. And then she got randomized to low-dose MDMA, because in that study, I'll talk more about it, but it was 30 milligrams, was kind of a low-dose active placebo. And she had had 2 of those sessions, and it was after that, a couple weeks after the second one, she called us and said she wasn't feeling safe and she needed to go to the VA. So we called her psychiatrist and she went to the VA, and when she got there she said, I need a safe place. I'm not feeling safe, but I don't want any medicines because I don't want to have to drop out of the study. So I'm thinking she may be the only person in the history of the VA system who was ever admitted with suicidal thoughts and didn't get any drugs for it. She stayed for 3 days and then she felt safe and went home and completed the study and did well.
So yeah, we've had other people who have had really severe suicidal thoughts that after the first MDMA experience, they didn't have them anymore. So that can be a very drastic thing that also happens. But she's the only one that had to go to the hospital for an increase.
You know, a lot of studies will not enroll people that have had suicide attempts or serious suicidal thoughts, but our position has been, if 22 veterans are committing suicide every day, what's the point of studying this if we're not going to include people who are suicidal? We want to make sure we think they're stable enough to tolerate the treatment, but we've taken people with
I think there was
history of
a
attempts.
question over here.
Yeah. Can you wait for the microphone?
Hi.
Just
This one
here
and then
you.
you. Yeah.
For the obstacles of PTSD, the lack of trust. For the obstacles of PTSD, for the lack of trust, you have civilian therapists with veteran participants. I was wondering if you ever thought about having veteran therapists with veterans, because I know that veterans like to talk or have more trust with other veterans as opposed to a civilian. I don't know. What are your thoughts on that?
We'd love to have some veteran therapists involved, yeah. I do see the advantage of having a veteran working with another veteran.
Yeah.
We always talk to the veterans about the fact that we haven't had that experience, and we're probably never going to understand it the way we would if we had the experience, but that we want to understand it as best we can. And the veterans have done well. We've been able to overcome that obstacle, but I think hopefully we'll have more and more veterans doing this work as therapists. That would be good.
Be great. I think there was, yeah.
Hi, Dr. Robert Estrada, San Francisco. My question's about the modulation connectivity, how MDMA is different with respects to how it modulates the connectivity compared to other pharmacological agents, SSRIs, things of that sort.
Yeah, there are some differences, and I don't feel qualified to really discuss that in detail, and also I don't think we really have time for that today, but it's a really interesting question, and others are going to be talking a lot more about that in the other talks. And Robin Carhart-Harris is here, David Nutt is here, Franz Vollenwitter is here, so there's some really experts in that can do a much better job of answering that than I can. Sorry.
Yeah.
Yeah.
I don't know if you want to address this now or later, but you mentioned that one of the things that you see is Jungian archetypes coming out. Can you give us some examples of what those might be?
About the archetypal things that come up? Yeah.
Jungian ones, yeah.
What was the question?
Archetypal.
You mentioned some of the things you see, that you
Some of the
witness,
things that we see, like archetypal.
and that you recognize Jungian archetypes.
Yeah.
In
I
what
think-
circumstances and what archetypes?
Well, okay, so we've seen a lot of symbols used and metaphors used where healing the trauma, people will imagine going downstairs and going down the stairs, and then if they need to come back up a little bit to take a breather, they'll do that, or they'll go back down, or the traumas will be in jars and they'll open the jars on a shelf. Lots of imagery about that. Images about the really good parts of themselves that have been locked away because of the trauma, and padlocks locking them. Themes about grief and how grief can be about larger, the world's grief.
Yeah, people describe the shadow, very directly. There are these big doors and they're locked and there's a lot of stuff back there. I don't want to go there. And then they go there and they say, oh, I found these beautiful things here. I didn't know there was anything beautiful, any beautiful parts of me locked away in this dark place with all the scary parts. And people, one guy described being around a campfire with a wise old man, a child, and the warrior, that kind of thing. Yeah.
Hello. I'm just wondering, when people will often bring up memories or get access to memories which had previously been repressed, do you see any negative consequences of that? Do you see any long-term effects where you might actually see a worsening of symptoms because they're bringing up these memories?
You're talking about memories that people hadn't had before that come up in the MDMA sessions?
Yeah, because with the MDMA sessions...
We
I'm
actually
assuming-
have not seen that. We haven't seen anybody have a new memory that they weren't aware of. We've commonly seen people revisiting something that they knew about and then remembering it in much greater detail, or having the time open up, like one firefighter who remembered the fire when 9 other firefighters died. In his conscious memory before the MDMA, he thought, this moment and that moment were only seconds apart. In the MDMA session, he realized there was 2 hours in there when he was sitting with these charred bodies that he had not remembered.
So maybe the memories fill in more, it seems like. But I think there are memories from childhood, too, that they knew about, but they didn't realize that they were traumatizing. It can be a common thing that'll show up.
So regardless of that, have you ever seen a worsening of symptoms when they do bring these things up?
Oh, yeah. Lessening of symptoms? Yeah.
A worsening.
Oh, a worsening. Okay, so there can be a worsening of symptoms after the sessions for a few days, more anxiety, because they've been delving into this material.
We're going to talk quite a bit
and we'll
about
talk about that.
part.
Mhm.
Yeah.
Yeah, thanks.
We really emphasize things could get more difficult before they get easier.
Yeah, I think
Yeah.
there's 2 there.
I'm aware of at least one study that's shown individuals with borderline personality disorder can have a paradoxical response to intranasal oxytocin in terms of decreased interpersonal trust. So I'm wondering if there might be any added risks to administering MDMA to folks with borderline personality disorder in terms of activating decreased interpersonal trust rather than increased.
I think there could be increased risk. We actually have not included people with borderline personality disorder, has been an exclusion criterion, which we have a lot of mixed feelings about, because I think it can be very difficult to diagnose when somebody has severe PTSD, and you treat that, lo and behold, the supposed borderline personality disorder may go away. But I think it's more a matter of, if people have a lot of those features, there's probably more risk to doing it in this research format, where there are only so many sessions over a certain period of time. I think it, you know, any paradoxical response like that could be dealt with if you have the right container. So I think it could be a very good treatment for people with borderline personality disorder, but maybe not so much in this setting, in this restricted protocol. Thanks. Yeah.
I want to answer your question. I was clinically diagnosed with borderline personality disorder and had a lot of trauma throughout my life. And I received 3 MDMA sessions over a period of 1.5 years, and I no longer meet the criteria, and I'm now studying to be a therapist. So,
Thank you for sharing.
Thank you.
Going back to the comment you made about the suicidal patient, and you said that she had received a lower dose. Do you think that that could have been part of why she was feeling uneasy afterwards? Like, and I don't know what the lower dose exactly was, but it was just enough to bring up the trauma and remove the blockages, but not enough to segue through it?
Yes, we do think so. In fact, after her, at that time, the protocol was 3 of whatever session, 3 of whatever dose you get randomized to first, and then a chance for crossover. Because she was the second person that had a lot of trouble with the low dose, so we actually amended the protocol. We didn't think it was ethical to keep asking people to do that many low doses. And they had some similar experience in Switzerland with the study with 25 milligrams. So it does seem as if the lower doses may be kind of activating to some degree, but not, so people can get more anxious, but not helpful. So we're actually in phase 3, we're not using low dose, we're using inactive placebo again.
Interesting, thank you.
Thanks.
Yeah. Oh,
Okay,
go
here's
ahead,
one
please.
here, and then we can take this.
Okay, hi, I'm from Oregon. I'm curious to know, you may cover this later, what are the sites that have been chosen for phase 3, and will there be additional sites chosen? I'm interested in working with other folks in the field of psychology and the therapeutic community in Oregon to expand these trials.
Thanks. Yeah, there is going to be a site in New Orleans.
No, Oregon.
Oh, Oregon. Okay, but not Oregon. You know, that's great. You know, right now the sites are pretty much set. Boston, New York, Charleston, New Orleans, Boulder, Fort Collins, 2 in the San Francisco Bay Area, 1 in Los Angeles, 1 in Israel, 1 in Vancouver, and 1 in Montreal. Those are the sites for the first phase 3. And those therapy teams are trained already. But we do want to train a lot more people for expanded access when that comes. And so we're going to be ramping up the training program again once we get phase 3 going. So we welcome you and many others to join us. Thanks.
I think there was one here.
I remember reading Stan Groff's work saying that some people with, this was LSD psychotherapy, some people with severe OCD are able to resist the effects and essentially like cancel them out. Have you observed anything like that with MDMA, that somebody can force it out?
We haven't had anybody with severe OCD. Yeah, Stan has told us about someone that resisted 1,200 micrograms of LSD and just got a little tired and wanted to play chess. But we have, it does, our impression is that people with maybe more obsessive traits may have a little more trouble letting go into the medicine. Not really sure, but I think we haven't had it be an obstacle. But again, nobody with severe OCD. Yeah.
I know that bipolar disorder is generally considered contraindicated for people taking MDMA, and I'm wondering, do you have any anecdotes of experience of people with bipolar disorder working with MDMA?
Well, we exclude people with bipolar type 1. The reason being, the protocols require tapering off all psychiatric medicines, and we'd be reluctant to have somebody with bipolar 1 go off all their medicines to be in the study. Doesn't mean that it couldn't be a good treatment. That, you know, that's not an absolute contraindication, I'm sure, for MDMA-assisted therapy. It just is for this stage of the clinical research. We've had a number of people with bipolar type 2 who have done well. Okay, oh yeah.
Here.
Based on the questions about geography and OCD, I'm wondering if you've noticed any difference in efficacy based on the larger culture of the people involved, like maybe regionally or between men and women with different socialization class differences, anything like that. And maybe the basis of the question is like, do hippies do better than other people?
Do who?
Do who?
Hippies.
Hippies. Oh no, because in the study that you'll see the results in a few minutes, the veterans, firefighters, and police officers, you know, probably at least three quarters of those people were naive to any kind of psychedelics, and in the first study too. So you know, we are in Charleston, South Carolina. So I mean, we do have maybe a different population than in California or some places where maybe psychedelics are more mainstream, but I think it, you know, overall it works.
Not necessarily a question about whether or not people have already had experience with psychedelics as much as does the previous openness and the culture of being open to talking about feelings already seem to have a difference. Like when you're treating maybe a veteran who's very much in a man box, as they say, do you see any difference between what those people are able to achieve in terms of overcoming PTSD symptoms and what someone who's already more willing to examine their feelings is able to achieve?
I would say no. The process looks different often. You know, if a veteran tears up a little bit, that may be equivalent to somebody in another study crying for half an hour, but we haven't noticed the results being different. Yeah.
Hi there. Thanks for being here and hosting all this and fielding all these questions too. I dropped you an email the other day, so this question is following on from that. And I kind of have 3 points of preface to my question without taking up too much time. But Mandy and I run a flotation tank center, so we work with veterans a lot doing sensory deprivation and see that being really effective. And I also do counseling work with vets a lot. So that's one point. Second point is I recently lost a client to suicide, so this is something that's kind of heavy on my mind right now. And the third is I recently only just tried MDMA for the first time. I had a lot of experience with psilocybin, but it was my first experience with MDMA. And I was amazed at the crash afterwards. 12 hours in a pretty deep hole of depression, which is kind of unlike my usual consciousness. So this leads to my question and my concern about working with vets, specifically with MDMA. I'm very, very concerned about driving them into a deep hole of depression and suicidal ideation after a session. And I'm just curious how much, it doesn't sound like you saw that come up, but I'm curious if there's any part of the protocol or the handbook on how to avoid that, what to do in that situation. How do I address that concern within myself?
Yeah, we haven't seen, I mean, it's an important question. We're going to talk a lot more about the support afterwards, but we have not seen that. We've certainly seen people have difficulty. We have seen people have more suicidal stuff come up, but we've been able to move through it with them. We've been able to help them move through it. We actually, when we tracked low mood the week after, we saw a higher incidence of low mood in people that got inactive placebo than who got 125 milligrams of MDMA, interestingly. So
that doesn't mean that people aren't tired and maybe having an inner process and not wanting to talk to other people, but you know, we support them through that. And if they're having a low mood, we support them with being with that low mood and seeing what their thoughts and their feelings are about that low mood, processing it.
I guess my concern is that window of time before they even come back to you. Like they have a session, have a great time, wake up the next morning with a gun on the bedside table and all these thoughts of suicidal ideation coming up, and before you even have an opportunity to get to them, they're back in that hole. That's the scenario that I'm just. Versus something like psilocybin, I've never had that experience after psilocybin. I always feel great personally, and I understand a lot of other people feel great after MDMA. I just wonder if there's different biochemistry with different people, and even if there's some way of screening for that. Obviously, there's something with the way that I process serotonin that put me into that hole afterwards that a lot of people don't have to deal with. I just wonder if there's any way of screening for that or preventing it.
Not that I know of. I mean, and again, we'll talk a lot more about it, but I think, certainly there's those physiological effects, but I think since we see people that have a lot of difficult stuff come up afterwards. That's why we have so much support, and people spend the night. They don't wake up at home with a gun next to their bed. They wake up in our clinic. They spend the night with a night attendant. We meet with them for an hour and a half the next morning before they go home. We talk to them later that day on the phone and every day for a week. We meet with them, for 3 more integration sessions with the option for additional ones if they need it. So we're very accustomed to having difficult stuff come up afterwards, but we're prepared to deal with it, and we prepare people very much for the fact that could happen. Also, I think the fact that we, haven't seen anywhere near the kind of, again, less low mood with MDMA than an active placebo. I think part of that is because there's so much preparation and attention toward processing what comes up that I think sometimes what happens for people the next day is things that have come up in the session didn't really get processed. And they also may not have the mindset for, the importance of processing them afterwards if they didn't get processed, but also we try to make sure there's a lot of emphasis on processing whatever's coming that day, which our impression has been decreases the likelihood of that much of a crash the next day. But we'll talk more about examples of this kind of stuff that comes up afterwards. But thanks for bringing that up.
Should we take a break?
I
We're
guess
supposed
we
to take
should,
a break at 10:30. So.
Okay. Okay.
Okay.
Sorry. My question is a direct follow-up to that, which is that a question I have is that in the studies you're using pure MDMA, and I think a lot of MDMA for recreational street use or whatever is not pure at all and mixed with things that have a real come-down effect. And I've noticed a real confusion with people about the crash afterwards, and I wonder to what extent that might be an issue about purity of MDMA. I think that could be huge, but I was really curious because I don't know. You're the experts.
I wonder that too.
Yeah.
I'm not an expert in what's in ecstasy, but I think it is much better to have pure MDMA.
Yeah.
Thanks.
So
So
we take a
maybe can we
15
make it a pretty quick bathroom break if you don't mind?
Okay. You're going to say 15 minutes or?
Yeah, let's start again in 15 minutes.
Yeah.